Friends, in this webinar, we shall learn about the common troubleshoots and the complications of intubation in a newborn. We will discuss how to identify and manage incorrect placement of endotracheal tube in the right main bronchus, placement of tube in the esophagus, complications during endotracheal intubation, and finally, the way to prevent them. On some occasion, the endotracheal tube may go into the right main bronchus, and this is suggested by the breath sound being heard mainly on the right side of the chest. No air is heard entering the stomach, and there shall be no gastric distension. In such a scenario, withdrawing the endotracheal tube and rechecking for the equal air entry on the both sides will confirm the accurate position of the endotracheal tube. The tip of endotracheal tube on chest X-ray should lie at the body of T2 vertebra. The correct position of endotracheal tube should be confirmed on X-ray. In chest X-ray, on the left side, endotracheal tube tip is at the right position, that is at the second thoracic vertebrae. However, if you look closely at the X-ray on the right side, the tube is too far inside as it is touching the carina and almost at the entry of right main bronchus, suggesting incorrect placement and collapse of the left lung. On the other hand, the incorrect placement of the endotracheal tube in the esophagus can be confirmed by absence of breath sound heard over chest. Air is being heard entering the stomach on auscultation with visible gastric distension, absence of mist in the tube, no carbon dioxide detected in the exhaled air. One should always remove the tube and do bag and mask ventilation and then reintroduce the endotracheal tube. The possible complications during intubation are hypoxia, that means a baby is showing low saturation or becoming cyanosed. The possible cause may be we are taking too long time to intubate or tube is not at correct position. In this scenario, we should halt intubation attempt and ventilate the baby with the bag and mask and try to reposition the tube. Baby may develop bradycardia or apnea after hypoxia or a vagal response from the laryngoscope or suction catheter. Here again one has to follow the same principles of ventilation with bag and mask and limiting the duration of intubation attempts to less than 30 seconds and oxygenation after intubation. We should also ensure that the baby is being monitored during the process of intubation. If baby develops pneumothorax, it may be because of one lung ventilation or inadvertent excessive pressure may be there. Once it happens, immediate measures may be required to drain it. One can prevent pneumothorax by using appropriate pressures and ensuring correct positioning of the tube. Baby may develop contusions and lacerations of tongue due to rough handling or if laryngoscope blade is too long. This complication can be prevented by proper application of laryngoscope and gentle handling during the procedure. One may develop infection possibly from the caregiver's hands. So, we would try to prevent this by paying attention to the clean techniques during the intubation. In this webinar, we learned that intubation should be done under monitoring with pulse oximeter. Also, ensure size of endotracheal tube and depth of insertion before procedure, so that complications are prevented or detected on time. Thank you.